Welcome everyone, good evening, and welcome to the latest in our series of monthly webinars that we do here at scan.com. So this evening's presentation will be done by Mr Numan Shah, who is a consultant trauma and orthopaedic surgeon who practices out of Salford Royal Major Trauma Centre. And he'll be talking about all things hip pain, so covering when you might need to refer to a specialist, and when you might need to refer for imaging. But just before we go into that, just by way of a quick intro, so my name is Tom. I'm the head of growth at scan.com. Scan.com, so we've been going since about 2017. So we're actually founded by an osteopath and a consultant radiologist. We're finding that they needed to refer patients into imaging. It was just taking quite a while. The idea was to aggregate the spare capacity that we found in the independent sector, which we've been doing for since 2017 now. So we have it's been what we call kind of a direct to patient proposition, but over the last year or so, we've really grown the side of the business where we have so lots of people like yourselves, lots of specialists, so osteopaths, chiropractors, GPs, specialist consultants who now use our platform to refer their patients in for imaging. So you can see on the screen is just a quick run through of how it works. But essentially, it takes seconds to sign up to our portal. It takes minutes to refer. I think probably the record we've had is someone from signing up to making their first referral took about 3 minutes. So you just put some simple patient details in. The patient will get a link to book, and by that they can essentially choose from a list of scanning locations, so they compare prices, browse locations, and then pay online. They will then go and have the scan at their chosen clinic. We'll then get those images and reports and then upload them back into the portal, so you can see them, and then basically decide on the best treatment, best follow-up care. So that's how scan.com works. If you do have any more questions or anything more you want to know about us, how it works, I think several of you are using us already, but we're sending around an email after this, and you can just reply to that, ask us whatever you need. Just a few quick bits of housekeeping before we get to the actual presentation as well. Happy to take questions all the way through during the course. So you type your question in the chat and then select send to everyone, so everyone can follow the discussions. Just looking at the chat, we had one question already. So do you have locations throughout the UK? So yes, so we work with about 200 scanning sites around the UK. You can actually if you go onto scan.com, you can have a bit of a search and see where those are yourself. But yeah, about 200 scanning centres. I should say the modalities, we look at MRI or for MRI, ultrasound, CT, multiple. So yes, if you do have any questions, pop them in the chat and then select send to everyone, and feel free to post those throughout the session. We also like to throw out a few polls, so keep an eye out for those, just quick kind of multiple choice, and we'll kind of I'll read out the results of those as we go. The session is recorded, so we'll send that and you can share it on afterwards, and we'll also provide certificates of attendance afterwards. And also with that email at the end, be great if we also like to ask for feedback on the session, and so it'd be great to get that. So with that out of the way, this session we're in for about an hour in total, so at 7:45. So we'll hopefully have a bit of time for questions at the end as well. But at that point, I will now pass over to Mr. Shah.
Thank you very much, Tom. Appreciate the intro, and we can delve right into it. And I would encourage everybody to ask questions along the way in the chat. I think it's just really opportune. I think something comes into your head and you just want it clarified. I'd prefer you just put your hand up or just put it into the chat. I think it should be absolutely fine. I'm very happy to be interrupted and field questions, not a problem at all. I'm just going to share my screen if that's okay. So that's going to change your screen to my screen hopefully in a second. Okay, so I think we should be up and running there. Tom, are we good?
Yes, all good.
Perfect. Okay. So I've already, I think you're going to one of the polls is going to be about the audience. So I've pitched this basically for primary care providers, GPs, osteopaths, physios, other allied healthcare professionals as well. And basically, I've tried to split it into things. What type of things I would personally like to see in my clinic, and things that could present to yourselves, and when is that tipping point where you should possibly be thinking about referring. Everybody's got their different clinical thresholds at which point they will refer. Some people will refer earlier, some people will be happy to manage the patients until a bit later, which is absolutely fine, and that depends on everyone's clinical threshold. I work in one of the...
Sorry, just to interrupt at this point, actually, just in terms of the poll, in terms of specialities.
Sure.
Still coming through, but about a quarter osteopaths, about a quarter chiropractors, and some sports therapists here, some GPs, and also quite a few physiotherapists as well.
Perfect. So I think hopefully we'll get the pitch right. So I'm one of the orthopedic consultants, low limb consultants, working in Salford Royal, which is a major trauma centre and a university teaching hospital up in the northwest in the UK. We're one of the two largest conglomerate hospitals, NHS trusts, in Manchester now. So we get a fair amount of referrals in, particularly for hip and knee problems, but we'll be talking about hip today. So just going to see if, yeah, I think, there we go. So just as a quick agenda, just to highlight what we'll be talking about. So talking about arthritis or degenerative joint disease. We'll be talking about a bit about trauma, a little bit about dysplasia. I'm sure, you know, my colleagues will have seen these happening when they're seeing their patients. We'll talk a little bit about labral tears, because I think people, sometimes when I get referred patients to my clinic, they have slightly different patient journeys of how they get to me. So we'll talk a little bit about that. We'll talk a little bit about infection, which I think is actually quite important, just so that we know from a safety point of view of what we should be doing. And a little bit about sports. But I'm not planning on talking about the whole plethora of problems that could occur. I thought I'd talk about the main topics that I tend to see, which make up the bulk of the referrals to my NHS and to my private clinics. So if I first touch on arthritis or degenerative joint disease, it depends which article you're reading or talking to, if you're across the pond. So just essentially, I'm sure everybody can tell, shows an AP pelvic X-ray, and it shows that there is some degeneration of the right hip joint. You can barely see the joint itself, whereas on the other side, on the left hip, you can see that there is some joint space at least. There's also a cystic formation. There's a bit of subchondral sclerosis, and there's a little bit of osteophyte formation, which is a bit of extra bone, which the body thinks, oh, I'm in pain, I'm going to stiffen the joint, I'm going to just throw off these osteophytes, bit of extra bone. It definitely stiffens the joint, but it doesn't help with the pain or help with the patient's symptoms. In fact, they do get worse. And if for a few of the astute members within the audience, you would have noticed that the patient also has got a little bit of scoliosis as well in their spine, a bit of a curvature. But this is not a dedicated spinal radiograph, so I can't really comment on that. But that's just by the by. So I think for me, pain is the biggest thing, and that's the biggest referring symptom that I will get for any hip problem. And essentially, I like to divide that into stages. So if they are getting nocturnal pain, essentially, which is night pain, that in my book is really severe, because imagine if I've got nocturnal pain, I cannot sleep. That is a type of sleep deprivation, a bit of torture, really. So I think for me, nocturnal disturbance is actually a very, very high marker for high pain, and also a marker for me to probably do something operatively for the patient. Not always, but more likely. If they're rest pain, let's say if they're seated and they're getting pain, that is probably not as bad as nocturnal or sleep pain, but it is still significant pain, i.e. that they're getting pain at all times, even while they're resting, and mobilizing pain, so functional pain. So whenever they walk, every step they take is painful. That again significantly affects quality of life, their well-being, their mental health, and we have issues with chronic pain coming in as well. So pain is one of those markers that I always say, you know, I get a lot of patients saying, well, I've got a very high pain threshold. Others saying that, you know, I don't take painkillers. So a lot of these discussions are around pain, and it's about how do we sort of bridge that with patients. So if they've got a high pain threshold and they're coming to you that I'm getting a lot of pain now, that probably means they're wanting us to take their pain seriously, and they're not making it up, for example. So that's how I take that when somebody says that to me. And also, if they are not taking any painkillers, this may be an opportunity to broach the subject of potentially, you know, taking or using some painkillers within reason, and obviously making sure we have their medical profile in place as well, so we understand which painkillers they should be taking or what should be prescribed by their GP. Function is a big one, as I'm sure everybody understands. In our mode of work, we're all constantly assessing patients. What can you do? Can you put your socks on? Can you put your shoes on? We also do an Oxford Hip score, which is like a functional score. It's a patient-reported outcome measurement score, which tells us, you know, if I've been seated at the dining table for a long time, when I get up, do I get stiffness in the hip, and various things. So assessing a person's function in relation to their problem with their joint, I feel is absolutely essential as well. And you suddenly realize, actually, there's simple things. I had a patient clinic today who was telling me that, you know, I can't do the gardening. I can't even make a cup of tea for myself. I can't make any food for myself. I can't get into my wet room. I can't get into my bed. So all of these things that we take for granted are really affecting all of our patients. So it's just nice to be able to understand that. And also talk about that whenever you're doing a referral, I think, to any specialist. I think we would certainly appreciate that. How is the quality of life affected? How are the particular hobbies that they like to do that they can't do anymore? You know, bowling green, doing, you know, any type of sports or fell walking or anything like that, which people really find that gives them the quality in their life. Suddenly you take it away, they can really become quite upset, depressed, and the whole problem can become a lot more compounded because they're unable to do those hobbies. So usually by the time I see patients, non-operative measures would have been exhausted. So what does that mean? Lifestyle modification. That includes adjusting their BMI as well. So making healthier choices, maybe Weight Watchers, getting fitter, getting more active, you know, giving up smoking, reducing alcohol intake, or stopping that altogether. Just making these lifestyle modifications. But that may also mean that you've got to maybe change the job you do. And that's a discussion that you have in primary care, where if they're like, let's say, a factory worker, they're standing for an 8-hour shift, let's say, and they're starting to get hip pain, then it may be that, do they need to start thinking about a bit more of a sedentary job or a different role potentially within the same firm? So those are the discussions that you can, you know, I would encourage, you know, all my colleagues to have with their patients, just so that you can really assess. And some patients will say, no, I've been doing this for 30, 35 years. I don't know anything else. Is all I can do, which is fine. But at least we're sort of getting them thinking and talking about that. Physiotherapy is absolutely the cornerstone of any treatment that I advocate. I do also like to add in hydrotherapy. So we're quite fortunate in Salford that we have got a hydrotherapy pool. If some places don't have it, then I do ask them that if you're taught any exercise by the physiotherapists, if you can sort of try and do those exercises within your local swimming pool. I do caveat it by the fact that you may feel or you may look a bit daft doing them, but it's always, I think, useful to just give people that opportunity that actually you can go and do these exercises, provided you're happy to do those in the pool. Because as we know, the buoyancy takes off the load from our joints. It allows our muscles to work a lot more efficiently. and the muscles are not having to support our skeleton. So that's where the physio is a lot more effective. And I do actually refer quite a few of my patients for hydro. Injection therapies, if I don't think there'll be many people doing injections into the hip joints apart from trochanteric bursitis or bursitis around the hip, which I'll talk about later. But that's injection normally something that we would do. But yeah, if you're confident and you're happy and you can do them under, let's say, ultrasound guidance as well, then that's a reasonable option that some patients can have. By the time they come and see me.
Sorry, you had just a quick question. I think you probably covered it off there, but it's from Andy saying, would injections be more considered in your clinic, e.g. ultrasound guided compared to non-guided?
Absolutely. So all the injections I do around the hip are guided. So if I do a troch bursa injection, it's under ultrasound guidance. If it's directly into the hip joint itself, intra-articular, then that's under X-ray guidance. So definitely, because I think you've got to make sure you hit the correct area of which is the source of their pain. I think that's essential and that's important. So I think from that point of view, it has to be guided. There are some injections that can be done, blinded, as in unimaged, i.e., such as with inside the knee, intra-articular injection to the knee, because it's a superficial joint and you can do that. But I strongly feel around the hip, it should be guided. So if they come and see me and they've got a hip like this and they've got, let's say, nocturnal pain, the quality of life is not good at all, they're finding day-to-day activities challenging, their hobbies are curtailed, then we would be having a discussion about a pain relieving procedure, which is essentially a total hip replacement. And this can be done conventionally, or this can be done robotic as well. So that again is a discussion that we have. The vast majority of hip replacements going on in the UK at the moment are all conventional. There is a higher propensity of robotic surgery happening. That's mainly in the private sector, simply because the NHS cannot afford to buy £1 million robot. So there are a few hospitals around the country that do have robotic robots in to do the surgery, but not the vast majority. So it's still conventional at the moment, but we're trained to do robotic surgery as well. So that's becoming, patients are asking about robotic surgery a lot more as well, and possibly in consultation with yourselves, that may be something that comes up in conversation as well. So it is something that it is now percolating into the general public and into that discourse as well. So this is, I do like to use this slide actually. This is when I was a fellow in Wrightington. We looked at some patients who had hip replacements done 50 years ago. So in order for this patient to have a 50-year follow-up, they had to probably have this surgery when they were quite young, so in quite demanding phase of their life. So I think this patient was around about in their mid-70s to late 70s, and you can imagine they would have been probably about 20, 24, 25, something like that, when they had the initial surgery. And you can see even then, when it was done by Charnley, the main pioneer when it came to hip replacements, it was done so well that it's lasted essentially this person a lifetime. So, and we've built on this legacy to develop much better technology, much better prosthesis, much better fixation techniques, and hopefully much better outcomes for our patients as well. So, but this was what was already laid down to us all those years ago. I'd now like to talk about a bit about trauma. So we think about trauma being, when someone's, let's say, been involved in a, road traffic collision, or they've had a significant, fall from a height. It doesn't have to be that case. They can have a fall. So a high energy fall is essentially anything above a person's height is high energy. Anything from standing height is termed as low energy. Now, low energy injuries mainly affect the elderly population because their bones are a lot more osteopenic, or they may have osteoporosis, weaker bones, so they may tend to fracture or injure themselves more. Whereas high energy types of injuries do affect more of a generation that are probably within their 20s, within their 30s, within their 40s, a very highly mobile type of population. I've just put this slide on there. Just if you look on the side where it says, we've circled the areas where if you were to ever see a radiograph that you send, let's say you send them for an x-ray, and you get an x-ray back and you're looking at it and you're thinking, whereabouts is this? You know, I can see a bit of fleck of bone there, or some injury there. It just sort of highlights what type of things attach to that part of the bone. And for us to then realize that if there's a bit of a fleck or something's come off, or a little tuberosity or a little bit of a small fracture, then we can then really identify which muscle group is affected, and we can sort of target and work with the patient regarding that as well. So it just gives you a little bit of that, you know, a bit of intelligence into, you know, what are we aiming for? What type of injuries have they got? What muscle group is affected? And how can we work with them? So I do like to use this type of landmark x-ray to just understand where things attach onto. And then there's fractures. You know, quite simply put, you have got fractures that affect us acutely or chronically. Chronic meaning if there's any stress fractures. So particularly in athletes, marathon runners, you might see somebody, the 50-year-old who suddenly had a, you know, rejuvenation, and they want to, they've maybe not been doing as many active things as they would like, and they suddenly go and do like a Tough Mudder or something, and suddenly you find that they've maybe not conditioned themselves enough to go and do that type of activity, and they have like they've gone through the training and they do the actual event, but afterwards they start to develop some niggles. And mainly people will get stress fractures in their feet. I've seen it in the tibia as well, in the shin bone. I've seen it in the femur as well, particularly in the subtrochanteric region. And also be cognizant of the fact that some of our elderly population may be on bisphosphonates, so that's normally prescribed for people with osteoporosis. Now, those type of patients do come in with something called atypical fractures, where they haven't had essentially any trauma or any injury, but they start to develop pain, bony pain, within their skeleton, particularly around the femur, again, around the subtrochanteric region, where I'm circling my cursor at the moment. And you get a little bit of a beaking appearing on the lateral aspect of that femoral bone. And that, if that is there, then they normally have a stress fracture that goes all the way across, and that's called an atypical fracture, normally related to bisphosphonate treatment, and then being on that treatment for a longer period of time than they should be. Normally the treatment is about 5 years, and then we normally take them off it. So that again, that's something to be cognizant of. Fractures, we assume them to be completely acute. Let's say they have an injury, they've got a fracture, they go to hospital. Doesn't have to be the case. Do think about it when you see a patient. They could have a stress fracture, they could have a chronic fracture, they could have you know, a fragility or frailty fracture. Sorry, Tom, were you putting your hand up there, or?
No, wasn't.
Okay, cool. So I think whenever we think about some type of injury, muscle avulsion injuries can be very, very painful, actually. Sometimes even more painful than bony injuries in stable bony injuries. So that's something definitely for us to think about and rule out. But let's say if we're seeing somebody, sorry, one thing I forgot to mention, I'll just go back to stress fractures. If we're finding that those patients, we're treating them, let's say we're mobilizing them or protecting their mobility. Let's say they've got a foot fracture, we put them into a walker boot. If their stress fracture is not getting better, very, very occasionally, if it's becoming very chronic, they may benefit from fixation. So at that point, it may be useful to refer them in. Muscle avulsion injuries, again, normally will resolve on their own. I would probably say 80–90% will resolve on their own, requiring little to no intervention from ourselves. They will definitely probably require some physiotherapy. But if they have a muscle avulsion injury with a bony injury, i.e. they take off, let's say, somewhere around the ischial tuberosity around their hamstring, or around their anterior superior iliac spine, then if the injury does not settle down, they may again benefit from fixation as well. So that's just something to think about. excuse me, stress fractures, as mentioned previously. Always be aware of previous injuries that they've had. So if they've had a previous injury, they may have recovered from it, but then they will have a lower threshold for having a recurrent injury in that pattern if they do it again, if you see what I mean, because the muscles will heal with scar tissue, they not heal with real muscle. So they have a slightly lower threshold for having any repeat injury, repetitive injury. But if you look at people who've had, let's say, bony injuries and bony fractures, bone is one of the only organs in our body that will go back to its natural state. So if I was to have a fracture of my thigh bone, my femur, just here, let's say where my cursor is, and we adequately fix it and we repair it, then over time, over about, let's say 5, 6, even 10 years, and we take out the metalwork, you may not even be able to tell that they had a fracture there, apart from a small telltale sign. So our bone is constantly remodeling. Our skeleton in its entirety gets replaced every 7 years. So we understand that there's a constant turnover of bone and of our skeleton.
We just have a question here from Michael. What is a fixation?
Fixation is what we utilize. So that could be a plate with screws. That could be essentially a device that we call a nail that we insert into the medullary cavity. Fixation is any device we use, any implant we use to stabilize that fracture, which means prevent it from moving. So we fix it on either end, stabilize it, and then allow nature to take its course to allow it to heal. Now, we do have patients in, obviously in museums where, prehistoric man, the earliest records we've had of civilization is when we have seen that a skeleton has had a bone heal. So over thousands of years, humans have broken their bones and they've healed. But civilization is identified by the fact that when somebody broke their bone, there was somebody to look after them, to feed them, to shelter them, to clothe them, etc. Because it will take a minimum of 6 to 8 weeks for that bone to heal. During that time, they will not be able to do anything. So there needs to be somebody to be able to look after them. That's how we were able to date civilization. And that's how bony healing, what we try and do is simply facilitate it. So we cannot cause the bone to heal. The body has to heal itself. But all we do is the fracture fragments, we get them close together so that the body has to do the minimum of effort to heal itself, because if it doesn't heal, that metalwork, the fixation, will fail at some point. And when it fails and the bone hasn't healed, you're back to square one. So you'll need to reoperate. And sometimes that does happen, and that's called a non-union. So fixation is just any way that we use plate and screws or a nail to fix a broken bone and do that fixation. One thing I would always say, we assess their mobility. We'll also assess their function. That's a critical thing about trauma. We assess their ongoing pain. We assess their x-rays for bones. So one thing I would always suggest we do is have a look at if they have got any other issues with their bone, and if they've got any breaks, then an x-ray is a reasonable primary care investigation to do. MRI can be utilized for soft tissues. I know some of my primary care colleagues cannot request MRI scans, which is fine. They need to go down the MSK pathway. And ultrasound scans can be used for swellings or tendon injuries or tendon problems. So x-rays for bones, MRIs for soft tissues, ultrasound scans for swellings or tendons. Now, an ultrasound is a dynamic scan. It assesses the movement of tendons. That's why it's good. It also is able to assess if there is a swelling or a cyst, and it shows up that quite well as well. So these are just rough guidance for how we can request things, but this is my normal algorithm for trying to assess problems with my patients. I'd now like to touch on dysplasia, because I know some of my colleagues do deal with dysplasia, and I'll define it and show what it means for me when I see people with dysplasia. So we've got another poll coming up, so I'll pause for that if that's okay.
Actually, apologies, I probably should have asked this right at the beginning, but just thought common pathology.
Yeah.
I imagine do lots of knees and knees and backs and things. Just good to gauge an interest of general knowledge about hip issues. So should be interesting. So yes, apologies. Should have done this a bit earlier, but
no, that's okay. That's okay. That's good.
Yeah, I mean, we can continue and then
okay. Sure. So when we're talking about dysplasia, it definitely affects more women than men, and that's just the morphology of how the osseous parts of the skeleton form. And I've just, if you just see on the X-ray, I've just drawn a bit of a line, so you can see that there is a red line, and that line essentially is showing the edge of the acetabulum as it comes into contact with the femoral head. So we draw a line from here and we draw a vertical line upwards, and that develops a center edge angle. And that center edge angle, if it's less than about 23 degrees, that means that person's got dysplasia. Dysplasia just means that there is less coverage of the femoral head compared to what it should be normally. The other thing is, so that's how we calculate the center edge angle. So if they've got less than 23 degrees, then they're at risk of not having enough coverage of the femoral head, which means that the forces going through the femoral head is a lot more in that smaller area than you would in somebody normal who had that acetabulum all the way around to there. So you can see the acetabulum, if it's shallower, that shallower part of the acetabulum will be taking more of the stress than if you had a larger acetabulum taking the force. So I hope that makes sense, but that is a subtle difference when it comes to dysplasia. So dysplasia is basically a shallower acetabulum taking the same amount of stress, whereas if you had a larger acetabulum and a normal acetabulum, it would be taking the same amount of stress, but per unit of acetabulum, it takes less stress, so it's not painful. But if you have dysplasia, you can develop pain, you can develop arthritis, you can develop inflammation. And it's important, if you do get an X-ray, that it does show that there's a concentrically reduced hip with a congruous joint space. So what does that mean? It means that the femoral head is sitting inside the acetabulum centrally, and also the space around the hip joint is uniform, i.e. the space equals to the space here. So this is a little bit actually eccentric and not necessarily congruous. I would expect in the primary care setting for the patient to undergo physiotherapy, strengthening exercises, hip girdle exercises, and also core strengthening exercises, because that is what really helps to strengthen up the muscles and improve the joints as well. And it's quite interesting, just on the radio I was listening today, that they seem to be reporting as a groundbreaking discovery, but there's more to do with knee pain. And they said that if you can increase the tone of your muscles in your knees, the hip pain, the knee pain will get better. So this is something that we've known for a long while, but you can just see how things like this in the general public and the layman's discourse, as it comes in, it is something that we've known for many years. But it's our job to actually educate our patients, for them to understand the mechanics of their body, and also to understand that what we're actually trying to do is trying to improve their function and reduce their pain. And I spend possibly a lot of my time in my clinic just educating patients and breaking down what things that they may have been told, myths that they've come across. And I just sort of have to break those down and then start again. And the typical one is that, Doc, I've done physio. I did it for a few weeks, and it didn't help me as much as I thought it would. And then I have to explain to them how physio works. I have to explain to them the longevity of physio, the exercises you do, how often you need to do it, and how you have to wait for time. You're going to be doing regular exercise for 2.5 months. You're not going to see much benefit. I know some people see a benefit sooner, but as a general public who are deconditioned, I say 2.5 months. And then at 3 months, you'll then see a big difference and start to see that change. And they say, okay. And that certainly, you can see the penny dropping and them really understanding. So our job also is educating as well, and making people understand their bodies, and also making them understand how is it that the treatments that we're advising actually work. And as soon as you get that buy-in, there's very few of my patients that will not accept the treatment or the management that I would advise them then. So they have that buy-in straight away because they understand. And I think that's key and critical.
Yeah. We have a question here from Sarah, actually.
Sure.
What hip girdle exercises would you give?
Yeah, so I think that's a good question. So I bow to the higher intelligence of my physiotherapy colleagues on that one. But essentially, you're looking for them to. One thing I do say is work within your limitations of the exercises that you can do, because what you'll find is that if you're trying to ramp up too quickly too soon, patients will just find, oh, I can't do those, I can't do those, I can't do those, I'm going to stop doing them. So I think from my point of view, I want them to do any exercise. It may be simple things, it may be simple quad exercises in, let's say, my octogenarian who's 80 odd, if they can sort of, even if it's a seated exercise, they'll sit in their chair, and if they can have a bit of a spread their legs out at 90, at their feet in front of them, 90 degrees, splay their legs out a little bit, and just literally levitate themselves off their chair a little bit. That just activates their quads, and just keeping their back straight and making sure that their core is engaged as well. So I think it's all one size does not fit all, and that's why you need to see the specialists. You see the physiotherapists, and they will sit with that patient and work out a bespoke management plan for that patient. I know we've got these sheets that are sent around and given to patients, but I think for some patients that's helpful, and I think people will just get on with it. People are focused. For some people, I found they need a little bit of education, they need a little bit of hand-holding, and they need a little bit of cajoling that, yes, you can do it, it will work, it will help you. So you've just got to tailor exactly what you want. So you've got to envisage what you want them to be like after the treatment, and sort of try and explain to them that by doing this is what we're aiming for. And again, you'll get that buy-in and get that help. But I think just the standard hip girdle exercises are very useful, and there is a program that we have in Salford where we will gradually step them up as they get better and better, do some proprioceptive work, initially work on their range of motion, making sure that's good, and then we work on their strengthening exercises. So there's a whole plethora of exercises and a program that we implement. I think I can. Are there some more questions, or am I good to go?
There's some just suggestions of other exercises and things in the chat. So I think,
oh, great.
Yeah, we can check those out in a bit. But we have actually had another question from Michael. So, is coxa valga coxa vara? So apologies if I can mask that. Like or Z type of dysplasia? So apologies if I completely mangle that question, but
yeah, no, that's fine. So yeah, I can see that. So I think what we're talking about is essentially the position of the hip, basically, and it depends on the angle that the hip makes for you. So coxa vara will be where you're essentially looking at the neck shaft angle. So we talk about varus or valgus neck angles, and if you look at this particular X-ray that I put up, this essentially is showing that this is a valgus neck shaft angle. So varus will be where essentially the neck shaft angle will be more acute. Valga is where it's more open, so more obtuse essentially. But you can get on all PAC systems now, usually there will be a way to annotate, so you can actually very accurately check the neck shaft angles, and you can actually make an assessment of how how obtuse or how acute their angles are. Now, in practice, does that make a difference? I'm not familiar with the terminology of Z dysplasia, unfortunately, Michael. I don't know if you can tell me a bit more about what that understanding is with Z dysplasia. But when it comes to if you've got a much more valgus and neck shaft angle, i.e. you're more upright, you can understand that the contact forces going at the top will be a lot more, and you'll be engaging a much smaller part of your acetabulum in that area. But if you have a more valgus, so neck shaft angle, you're going to then find that they've got more coverage of their head, and they should actually have possibly better symptom control. If even if they have got dysplasia, it may be better symptom control. So that's just something to think about. Okay. So I hope that's clear. Is that okay? I can't see the chat, but I'll carry on.
Yes, I think that's all clear. And the Z was a typo, by the way. I essentially
Okay.
what was on the auto key, but it was that.
Yeah, that's fine. So I think so. I think it's really important to talk about valgus and various neck shaft angles, because we obviously deal with that on a constant basis. So I'll just reiterate. I think I might have just mixed up a couple of the terminologies just to make it crystal clear in people's minds. So valgus will be a much more obtuse angle. Varus is actually much tighter. So that does have an effect on how the dysplasia works as well. So valgus is more open, varus is much shorter. Okay. So I do utilize PRP injections for platelet-rich plasma. There is probably about 60 to 70% of my patients do benefit from it from when we've looked at the data. And this is essentially I'll talk about a bit later and what sample we get and how we inject it. But this I've found is really helpful in reducing inflammation. Now, I'm very careful in not mentioning that this is in any way helpful in regenerating cartilage or regenerating tissue or anything like that, because I don't feel there's any evidence for that. Where I do feel it's got evidence is in its ability to reduce inflammation. The other injection that I do like to utilize is Ostenil, which is hyaluronic acid, and I also utilize steroid as well in patients only when they have if they've got arthritis and it's grade 4 end stage arthritis. I'm just going to speed up a little bit, actually, taking a little bit of time. Now, if we catch them early enough and they don't have arthritis, then we can do a procedure called pelvic osteotomy, which essentially works to increase the coverage of that femoral head. So that if the head is covered only this much, the osteotomy essentially is breaking the bone, realigning it in 3 planes and bringing it further down and securing it with some wires, i.e. fixing it with some wires or with some screws. But that can only be done provided the patient does not have any arthritis. So that is a diagnosis that should be made early so that interventions can be managed and done earlier for that patient. And that gives the patient the best chance of having their native hip, i.e. their normal hip, surviving a lifetime for them. But if we leave somebody who's dysplastic and they develop arthritis, then we are paving the way to a hip replacement eventually. And I do see a lot of patients coming to my clinic for that as well. Like I mentioned, total hip replacement is something that is the end stage. I'll touch on the labral tears because that's something that we do get referred quite a bit. So labral tears have got different types of pathologies why they happen. Now, I hope you can see this MRI image which shows the arrow showing an MRI ACL image, coronal image that essentially shows a cleft in the actual fluid. So this is an MR arthrogram. So there's a cleft just there between that labral tissue and this other labral tissue, which denotes a labral tear. Now, why do labral tears happen? You can have a cam lesion. So if you've got a bit of bossing over your head and neck area, so this cam lesion can basically be an extra bit of bone that's grown, or it could be just the morphology of your normal hip. You could have been made like that. And that you can imagine as you are abducting and moving your leg side to side, it's just bossing on it's just hitting that labrum and causing it to tear over time. And it is a degenerative process. And apart from a cam lesion, you can have a pincer lesion, which is over coverage, which you can see here. And that again can be that the acetabulum has just overgrown too much. And again, this is a morphological problem, a developmental problem of how your native hip has formed. And that again can be a problem for people as well. I always advise, please examine the patient so that we can understand where the impingement is. So you can do a flexion, adduction, internal rotation maneuver, a flexion, abduction, abduction, and external rotation maneuver, just to understand if there are any impingement signs. And it's always useful in letters to hear about these. Have they had any physio? Again, physio, I think we find that if you don't refer people for the correct type of physio, people will have a bad experience of physio. I think so. That's the crux of it. I always say rubbish in, rubbish out. If you do not know what you're referring somebody for, be it for a scan, you can scan anybody for anything. You'll scan somebody. Let's say they've done the study where they've scanned just everyone. They're asymptomatic. They scan their backs, and they found that a high proportion of people actually had positive findings on the MRI scan, but there are no clinical correlation. There are no symptoms. So I think we've got to be very, very guided by which modalities we request, i.e. scans, CTs, ultrasounds, etc., and why we're doing them. So it answers a clinical question for us that we've detected in the history and the examination. That's absolutely key. Otherwise, it may give you an incidental finding, and it can turn out to be a red herring. So I just want that's one, I think, main aim is to make sure that if you ever scan or refer anybody, is you ask that clinical question. So that really helps to guide you as the clinician when you see them with the results. Actually, it's proven exactly what I was thinking. I can do my management plan as I manage this particular problem, for example. So I would also advise, if we can in primary care, is to get these type of patients who are we're querying labral tear to physiotherapy, because that can certainly help, because any type of degeneration within the hip, be it a labral tear, be it arthritis, weakens the muscles, it increases the tone of the muscles. It's all about working with the physiotherapist to make that muscle movement a lot more efficient, and just making it more meaningful for when they are striding up, when they're walking, when they're doing their physical activities, and really utilizing the expertise of our physiotherapist colleagues to really help our patients. And I think if physio done right, I've had patients who were listed by some colleague, let's say I saw a patient recently who'd been listed for a knee replacement. They ended up coming to my clinic for whatever reason. I counseled them, and I felt, and I just got a feeling from talking to the patient, that I didn't feel that a knee replacement was indicated at that moment in time. And they turned around and said, well, I'm happy to try anything else that you may have on offer. I said, can we just try some simple physiotherapy? Because I think if I can strengthen you up, I think that's going to go a long way to alleviate your symptoms. And lo and behold, that patient has not required a knee replacement to date because of the rehabilitation, the buy-in that he had. So I think it's that constant evaluation that we should be doing with all of our patients. Now, again, you may not be able to request an MR arthrogram. If, let's say, you've done your history examination, you've got an X-ray, but they've still got these provocative movements indicating impingement, then by all means refer them in, and I will organize an MRI arthrogram for them, which is with the contrast, which is what you're seeing there at the moment.
Just quite pertinent, I think we covered it, but Paul has a question. If you're suspecting a traumatic labral tear, would you arrange an MRI or refer specifically for an MRI?
Yeah, so is a question that should he refer for an MR arthrogram? Is that what the question is?
Yeah, so if you're suspecting a traumatic labral tear, would you arrange an MRI or refer specifically for the MRI or the angiogram?
Yeah, I would definitely organize an MR arthrogram. because there's two questions I want answering. One, is there a labral tear? And is there any degeneration within the hip joint? Now, if there's no degeneration and they have got a labral tear, it makes them to be a much better candidate for hip arthroscopic surgery. So that's keyhole surgery into the hip joint to try and repair that labrum that's torn back onto the acetabulum. If they have degeneration, then if hip arthroscopy was done, they're likely to have a not as a favorable outcome as somebody who doesn't have arthritis or degeneration in that joint. So if you've already got degeneration in the joint, hip arthroscopy is less likely to be effective, in which case I would probably inject them and just, again, do some strengthening exercises with my physiotherapy colleagues and really get them rehabilitating and utilize conservative measures as fully as possible. And it is a waiting game. I may give them some other injections, and then we just have to wait for the hip joint to become more arthritic to a point that I would need to do hip replacement surgery. So I would definitely wait. I wouldn't jump into doing any type of hip replacement surgery because at that age, they're probably going to be young, and it's all about cajoling them and helping them come to terms with the new normal for them with regards to the hip joint. So that's what I would do. Okay, I hope that's clear. I've mentioned injection therapies I can utilize for some of my patients with labral tears, mainly a steroid injection, because it does what it says on the tin. It's going to get rid of the pain, even if it's for a few weeks or a few months. It's going to do that. In some patients, I have gone back to doing PRP injection after a steroid injection because that can help with inflammation, reducing inflammation. It's a little bit more biological. It's a bit more accepting by the patient. And it's all about patient choice. And it's just, I do put it to them and then see what they feel and what they think about it. I've put on their hip arthroscopy. It does have a limited scope, pardon the pun, but it's basically because of the fact that the bandwidth of doing hip scopes is becoming less and less. As we're doing it more, as we have done it quite a bit in the past, we're now realizing those results that are coming through are not as favorable as we would have liked, even though some patients do quite well and they can get cured from their pain. Others have not done as well as we would like. And one famous person that had that was Andy Murray, the tennis player. So he went to Australia to have his hip arthroscopy done. That was, I'm not sure if it was much of a success, and that's why he ended up having hip resurfacing done in London by a colleague. So I think that's the essence of it, really. So we need to understand is athletes work in a different time frame to the general public because they know they've got a short span of work within their field of expertise, and they just want to be doing as much as they can within that limited time. So they will go for any treatment that gets them back to where they should be, but that treatment may not always be in their best interest, or will not provide them with the long-term benefit, which somebody who comes and sees me from, like an average patient, they just want to get better, get cured, and have that cure for a lifetime, essentially, if possible. So that's how sometimes we've got to tailor what we advise our patients according to what their profession or what their hobbies are. So again, I don't want people taking it away and saying that, oh, hip arthroscopy doesn't work. It does work in certain scenarios and in certain patients for certain clinical problems.
We've actually got two questions here from Liz and Christy about steroid injections. I would also say, we're due to finish in 1:45, so hopefully we'll run on a couple of minutes, but I'll just read out these two questions. So first one, Liz, is how many steroid injections would you do in a joint over time? And the second one is, would you avoid steroid injections for degeneration of hips due to it possibly affecting the density of the bone?
Correct. So thanks for those questions. So I think those are things, I was just telling my trainee about that today as well. So you have got, I think, I'm not going to call it a myth, because I think there is some truth in it. So I know a lot of colleagues feel in primary care that doing 3 injections is the maximum you can do in any joint, a hip or a knee joint, for example. I don't necessarily agree with that, in the sense that I've had patients who have come to me after 2-3 injections. I inject them, they get better. So it's not that I'm doing anything special or wonderful. It's just that it can sometimes still work. So I wouldn't put a limit on there, but I do say the first one usually works really well, fantastically well sometimes. Second one works probably about 70% of the time. And the third one will probably work about 40% of the time. And then after that, it sort of just tails off. So I wouldn't put a figure on it, but definitely the more you do, the less effective it can be over time. And with regards to doing multiple injections, I only do one. I will only advise doing a steroid injection once every 6 months. And in my practice, I've not had any issues with any further problem with, let's say, osteoporosis or weakening of the bones or any steroid-induced fractures. So I've definitely not seen that. And that's how we've been doing it for many years, and it seems to work fine. So I've not seen that problem. I'll just move very quickly, conscious of time, and then so we take questions near the end if people just put them in the chat. Is that okay?
Yes, sure. I mean, I think we've had a really decent amount there, but by all means, if anyone has any
Cool.
questions, pop them there.
So I just wanted to really touch on infection, because I think that's something that worries everybody. Now, if you have a painful, swollen, hot, or erythematous joint, a bit like you can see in the picture, then that's something to think about. That probably needs referring to ED, not even to me as in a clinic. That needs to go to ED. If you've got a joint that's lost function, and has that picture as well, again, you should go to ED. If they've not got any, if they just lost the function, then we need to see, are the muscles, are the tendons, are they working adequately or not? That's the other question. Has there been recent surgery? Is there a scar? Like you can see in this picture, there is, pustules formed. There may be a bit of discharge lower down in that wound. So if they're discharging from recent surgery, again, I would have a low threshold to refer that patient into that surgeon's clinic so they can review them sooner rather than later. If you put them onto antibiotics, I don't think that's particularly harmful. The only reason I would say to stay off antibiotics is if you're sending a patient to A&E, provided they're systemically well and they're sensible, i.e. they're going to tell somebody that I'm not feeling so well so that somebody can put them onto antibiotics, then leave off the antibiotics, let them be seen in A&E, let them have an aspiration of that joint if that's indicated, because as soon as you give them antibiotics in primary care, it's going to kill any bugs potentially in that infected knee, and it makes my job a little bit more difficult to find out who the enemy is, who's the organism I need to fight. But if they're showing systemic signs, i.e. a temperature or tachycardic, or they're feeling fluey or unwell, no harm in giving them antibiotics. So it is purely a judgment call. And if you feel that you want to err on the side of caution and give them antibiotics, that's absolutely fine and reasonable. But if there is a window that they can reasonably get to A&E and they'll get seen and they're going to tell somebody that they're feeling unwell, then you may have a window of holding off the antibiotics. Systemic signs I've talked about. So if they are having an infection, but you think it's grumbling, it's not really that painful, it's not that swollen, there's no erythema, they're just getting a little bit of pain, then it's reasonable to get an x-ray and see if so infection is one of those things that I think can present in many guises. Everybody's got different thresholds for when they refer people for pain. Everybody's got different thresholds for when they refer people in for infection. So again, this is an individual call, to be fair. But if if the patient is having antibiotics and you think there's just a cellulitis, give them some flucloxacillin, because Staph aureus is the most common pathogen, and get an x-ray, make sure the underlying metalwork or bone is absolutely fine. I think that's entirely reasonable. If you find that the x-ray is showing some signs, then refer them in. And what I would normally do if they've got a joint replacement is do a CT SPECT scan, which is a positron emission CT scan, and it shows me very specifically this red spot. It basically lights up the whole image if there's any increased infection or any type of increased stress in that joint. It will show it up as a bit of a target essentially. And this is not an infected case, but this is a case of a knee replacement that has not had the patella resurface. Now, I don't resurface the patella in 90% of my patients, so I completely get it. But in this patient, they've had the knee replacement and they're getting pain at the front of their knee, and we've done a CT SPECT, and it shows that there's a high stress area in that patella. It means that this patient probably, not always, probably will benefit from having a secondary procedure where we will resurface their patella. But that is done very, very occasionally. But this was just to demonstrate how powerful investigations can sometimes be and really can guide what you do. I'm just going to touch on the sports side of things very quickly, and I think we should be ending. When you see somebody from the sports side of things, they may have a muscle sprain, most likely. That will repair and heal on its own and get better. Occasionally, if they've got a bony avulsion not getting better, please refer them in. Trochanteric bursitis, which is probably a huge amount of the work that I do. I see patients constantly with this problem, and it's known as different syndromes as well. And in essence, it means the same thing. So this ultrasound scan is sort of delineating what the problem is. So you've got bone, which is hard. You've got the muscle that's overlying the bone, and sandwiched in between these tendons, you've got the bursa. So if the muscle is tight and it's bearing down on that bursa onto a hard bone, you can imagine anything between really strong muscle, hard bone, and it's rubbing, causes friction, it's going to get inflamed at some point or another. And my treatment algorithm for these is to usually inject them with ultrasound guidance, because that's why I make sure we're in the right place. And that can be with PRP, or that can be with steroid. And I don't worry about steroid causing disruption to the tendons or causing a tendon rupture, because I will not be giving them an injection for another 6 months. And usually that is more than enough. So ultrasound guided injection, and then I will refer them for physiotherapy exercises, including hydrotherapy. It's eccentric exercises and ITB stretches. So that allows to slacken the muscles, allow the muscles not to be as hard pressing on that bursa. And that is the main reason why the pain gets better. The injection helps in the short term, but it's the physio that really helps as well. So I always tell them that my intervention is a short part of the treatment. The physiotherapy and the rehab is a much longer and much more important aspect of their treatment. So if I can frame it like that, then they again have that buy-in and they understand. And this is all part of the same syndrome, gluteal tendonitis. And obviously the exercise that I advise them to do. Sleep disturbance is an issue when it comes to sprains, because inflammatory pain does become more apparent at nighttime. The reason why is because when you have your normal bodily processes, they will all start to shut down because they're a normal body process. Circadian rhythm kicks in. Nighttime, all processes shut down. But if you have inflammation or an injury or an abnormal type of process going on, which is inflammation, which is not normal, it's an abnormal process, that inflammation actually has no feedback to calm it down. So at nighttime, you will feel it more. Hence, when you go to sleep, when you're lying down and you've hit your elbow on the door, or you've got a cut or you've had an injury, when you go to lie down, you're like, okay, now I can get some rest. Suddenly, it starts to throb, starts to ache, starts to become painful. So that sleep disturbance is there as a result of the inflammatory pain. So that I thought I'd just emphasize that when it comes to sports injuries. And again, PRP versus steroid injection is the clinician's call as to what they feel is going to be most useful. And I've just put a syringe here that I use of the Arthrex ACP system, and you can see that in the gloved hand you can see the red blood cells which are separated and the plasma which is separated, and within the syringe we actually siphon off the plasma, and this is what we inject. We don't inject any blood, any of the red blood cells, because that in it actually can be an irritant. So we avoid it at all cost, actually. And it's just the yellow plasma which we take up into that syringe, pop it off, and inject that into that area. And like I said, it'll be image guided. I was just going to show you this X-ray very quickly, this YouTube video. I thought it was quite interesting of where X-rays are going and imaging modalities. And it just shows low dose radiation X-rays showing how we can show movement in the hip joint. So we can just see how it shows it very dynamically. So they've done this for the spine, they've done it for hips and knees, etc. as well. So that'll bring me to the end now. Okay, if you've got any questions, anything else, more than happy to field them. Sorry about the timing.
No, not at all. I think just a function of all the material that you've gone through and all the questions we had as we went through. So, yeah, like a couple of minutes. So, I think there's probably just a couple of housekeeping questions more than any directly, but I think a lot of comments saying very informative. Thank you. So, the field is best consultant so far.
Wow.
We do have a raised hand. We'll see if I can. Nabil, did you have a question there?
Go ahead, Nabil. You're just muted, so you can unmute yourself. Go for it. Or put it into the chat if you want to.
Yeah, if you can try put that into the chat, I'm sure we'll get to it. Okay, well, I'm sure if you can here we go. There's one actually here from Lucy. Do you think there's a relation with hip problems, low back stiffness?
Definitely. So again, I spent my life in clinic trying to determine, is this hip pain? Is it back pain? Is it knee pain? So the back is connected to the hip, certainly. The hip is connected to the knee and vice versa. So I know it's probably not groundbreaking that everything is connected, but it is important to think about it, because I've seen patients who've had knee surgery, knee replacement surgery, and their pain is no better, and it was actually their hip arthritis all along that was causing their pain. So I think that's a really, really valuable question, Lucy, and something I didn't actually mention, which I should have, which is always examine the joint above and joint below. I know we taught in medical school or in our training at university, but I cannot emphasize it enough. When you're getting to your level where you're determining management plans for patients, and it can make all the difference to patients. So 100%, if they've got lower back stiffness, and you can imagine if the back is stiff and I'm having to bend forward to get something, and my back is not going to bend, my hips are going to do all the bending. So and that's going to put an excessive force on my hips rather than using my back muscles to do that. So 100%, very, very important that we rule out back stiffness, and we work on the back symptoms and work on strengthening exercises, work so that, I think key thing is to identify it, and then you can, once you get to the diagnosis, I always say, you get to the diagnosis, you can then work out, once you know what the problem is, you can then work out the correct management plan for that patient. And definitely it all keys into the actual ethos of what we're trying to do, is making sure that we're treating the patient at the right time, at the right place, by the right person. So we're getting it right first time. So, and that getting it right first time is important from the very first moment you see that patient, actually, because they've not been they've not had any other they have not had any treatment, and they're essentially a fresh canvas for you. So I think about all the different things that it could be before you see the patient, and then really work through it, and you will find that you will evolve your practice as you go along if you think like that. Definitely.
Tony actually says, I've had 3 patients with knee surgery when the hip was actually the problem. Well,
and you see,
yeah.
It's unfathomable, but it happens.
Yeah. There's another question with Georgia actually just mentioning, so shockwave seems to be something that patients are bringing up more and more above and beyond rehab injection modifications. So is shockwave therapy something that you would consider for persistent lateral hip symptoms?
Yeah, I think I've not had a really good experience with shockwave therapy. I know when I was training, we were using it in certain patients. We were using it quite a bit for plantar fasciitis. And I believe the way it's sort of working is by causing micro trauma, and sort of trying to instigate some of that healing property that our body inherently has. I've not seen in practice or in the literature for it to be, it may be another modality that may help. I'll never rule out anything. If we've tried everything and we're near the end of what we can offer patients, then if this is something available to you and it can be done competently, by all means, you can be open and honest with the patient that we'll trial this and see if it works. It may not work for you, but it's worth a try. It's not harmful. Whereas I say that, but I've seen some shockwave therapies which have caused quite a bit of bruising and a bit of discomfort. So we have to be careful. But that's what I've sort of altered my technique when I do my PRP injections. Is I do a bit of a barbotage, which basically means I cause a little bit of micro trauma. So if let's say this is the hip that I'm injecting, I will sort of enter the skin in one point, but I will go in different planes with using that same point to irritate that tendon, to cause some micro trauma. And with the PRP, because that already contains the cells and the cytokines to help improve and alleviate that pain, and it has the correct mediators, with that micro trauma, accompany that with the PRP injection, I find that really can be very effective. So it achieves the same outcome that the shockwave treatment does, but I simply use a needle rather than using the probe for the shockwave therapy.
That does look like it for questions. So
Super.
so this point, so yeah, just to reiterate, we'll send around an email after this to all participants. We'll have the recording on it, just some more information about us as well. And if you do have any questions about the session or anything else, just please get in touch. And we'd also love if we give some feedback on this session as well via that email.
Yeah, definitely.
And, a massive thank you, Mr. Shah. Really incredibly informative session there. So a huge thank you to you. Big thank you to everyone who's participated as well, and for all the questions and participation. A couple of questions about can we get the slides?
Yeah, happy to.
Okay.
I can email them, and I'm more than happy. You know, nothing's copyrighted, and use and abuse as you wish. If you want to get in touch with me, you can. My email address is there. You can get in touch with me as well. I've no problems about anybody getting in touch and having some sharing a bit of knowledge as well. You've got one as well, actually, Tom. Well done. Very good host. There we go.
Yes, yeah, I'm gonna thank you very much. Well, yeah, with that said, thank you very much, everyone, and hope to see you soon. Bye.
Okay. Bye-bye. See you later.